Thank you, Volker. Thank you so much, and thank you for the invitation to come to Berlin to participate in this conference in this beautiful space and to talk about managed care, a term that is quite a controversial term in the United States and I think around the world, and at the same time is a kind of represents what we call an organization which now basically controls the health insurance and healthcare system in many respects in the United States. So my goal today is really to try to give you a sense of where did managed care come from? What's the history of managed care and of managed care organizations in the United States? So what's the history of managed care? What are the key issues on the managed care agenda today? How did managed care evolve? And what does managed care perhaps mean in a German context? And for that, I'm looking forward to the conversation later with Volker and with all of you. What I'm talking about when I'm talking about managed care and managed care organizations in the United States really requires a little bit of history. The health insurance system in the United States, began in the early 1930s during the economic depression. And health insurance in the United States begun by healthcare providers, by doctors and by hospitals. And the health insurance system that they created, which lasted a very long time in the United States, was a system in which there was a clear split, a clear bifurcation between the provider of care and the payer of care. The provider provided the care, the provider delivered the care, and the payer paid the bill with no questions asked. Under managed care, that flips. Under managed care, the provider submits a claim, perhaps, to the managed care organization, but the managed care organization blurs the line. The managed care organization uses tools and techniques to try to encourage lower cost, higher quality, etc. So the provider no longer has nearly as much autonomy. The provider perhaps is not paid as much. And there's this potential battle that ensues. But the goal is the payer now is using these tools and techniques, which we'll talk about in a few minutes, to try to encourage better care at lower cost. So why did this change take place, and how did it take place? In the early 1970s in the United States, policy analysts noted three major problems in the healthcare system in the US. First, costs were rising dramatically. You may not know this here in Germany, but in 1970, the United States spent less on healthcare on a per capita basis than the Canadians did, and they spent the same amount as the Germans did, basically. But beginning in the 1970s, the US spending on the healthcare went up. Well, healthcare spending in other countries also went up, but at a much slower rate. And so, the analysts started saying, well, why are healthcare costs growing so fast in the United States? And the answer that they began to give, the economists began to give, was, oh my gosh, it's because the doctors are paid a separate fee for every service, so the more they do, the more they get paid. That was one claim that was happening. At the same time, in the early 1970s, health services researchers began to notice that there was extraordinary variation in the utilization of services around the country and in the cost of care around the country. And it was explained by physician autonomy. The physicians had the autonomy to do what they want, so based on their training, they practiced in very different ways. So there was this extraordinary variation, and that was viewed as a problem. And the third problem that got a lot of attention in the early 1970s was that the physician workforce was increasingly specializing, and as it specialized, there was less and less coordination of care. There was no longer that family practice physician, that general practitioner, to take care of his or her patients. And so these three problems, rising costs, increasing variation in the delivery and cost of service, and lack of coordinated care, created a policy window to do something different. And then the policy analysts said, well, you know what? There is a solution to all three of these problems. There's a solution to the rise in costs. There's a solution to the variation. There's a solution to the uncoordinated care. And that solution is, quote unquote, Kaiser Permanente. Kaiser Permanente had been a small little plan operating in California, but Kaiser presumably had an answer for each of these problems. If you're worried that fee-for-service medicine leads to higher and higher inflationary costs, well, the Kaiser model said, you know what? Kaiser's going to capitate Permanente, the Permanente Medical Group, and then the Permanente Medical Group is going to put the physicians on salary. So the docs will no longer have an incentive to do more and more and more. Kaiser's also going to have a primary care gatekeeper for all of its members, so you'll coordinate care. Kaiser's also going to issue practice guidelines to the physicians, which didn't really exist in the traditional insurance world. And Kaiser's going to have its members get their care at the Kaiser Clinic and only at the Kaiser Clinic, so that the Kaiser system will be able to control the entire, delivery of care. And Kaiser's going to focus on prevention. And so this notion that this Kaiser model could solve all the problems of the healthcare system started to get some notoriety. And that led, in 1973, to the enactment of what's known as the HMO Act of 1973, Health Maintenance Act of 1973, the Health Maintenance Organization Act of 1973. The idea was we want to replicate Kaiser around the country. Only the doctors hated Kaiser because the doctors wanted to practice in their own office. They didn't want to have to practice in a Kaiser clinic. The doctors didn't want to be on salary, and the doctors didn't want to have their autonomy questioned. And the consumers generally hated Kaiser across the country, in part because the doctors told them they didn't like Kaiser, but also because they didn't want to have to go to the special clinic. They wanted to be able to go to their doctor's office and have total freedom of choice. And so while the HMO Act was passed in 73, and this is what I would call managed care 1.0, it didn't take off. Okay, fast forward 20 years. All the same problems we had in the early 70s, we see again in the early 1990s. Only in the early 1990s, now Bill Clinton is president, and he's saying we should have national health insurance. The traditional for-profit insurance industry says, all right, you know what? We don't want national health insurance. We can provide the benefits of Kaiser without the burdens of Kaiser. We will give you a network. We can call that network an IPA, a POS, a PPO. Basically, we will have a network of providers that we can have a little bit of control over, but the members will still have a lot of freedom of choice, so consumers will like it. We will issue some practice guidelines. We will have some gatekeepers. We can control costs a little bit. But basically, we, the for-profit insurance industry, will sort of adopt the mantle of Kaiser. And the politicians love the idea. And Wall Street loved the idea. And so all of a sudden, every employer was saying to their employees, you have to join one of these quote-unquote managed care organizations to get your health insurance. And so that happens in the early 1990s. And what happened soon after? Well, the doctors hated it. The consumers hated it. There was a backlash against it. The doctors felt like their income was being reduced, their reporting requirements and the administrative burden of, sort of being a physician was magnified. They didn't like the fact that their autonomy was being questioned. They would have to call an 800 number to get permission to do whatever they wanted to do often. The consumers hated it because even though they were getting these networks of physicians, it would always seem that their physician was not in the network that they wanted. Plus, they had to now worry that the doctor would have to get permission to provide the care services that they needed. So the backlash continued. So then we got to the early 2000s, and we were in the same place that we were in the early 1970s, and the same place we were, 30, 40 years earlier. And this time, the insurance industry said, you know what, we have a new idea. We're ready for managed care 3.0. We now have all sorts of new data available to us. There's been a revolution in big data, in artificial intelligence. There's all these revolutions going on. And we can come up with these metrics to measure performance by doctors, by hospitals, by clinics. We're going to try to change how we pay the doctors or the hospitals based on their performance on these metrics. We're going to use value-based payment. Pay for performance. And so that becomes the new mantra of managed care. All these new value-based payment models come into effect, really in the last dozen years or so. But meanwhile, when we look at the problems of the US healthcare system, they're the same in 2023 as they were in 1973. In 2021, the United States spent over 20% of its gross domestic product on healthcare. Over $13,000 per person on an average per capita basis. And at the same time, there's still extraordinary variation in the practice of medicine. There's still extraordinary lack of coordination of care. There's still extraordinary inequities and disparities in who receives what care. There's both overutilization and underutilization of care at the same time. And increasingly, there's this partisan debate in the United States over what is the future of healthcare and what should it be? And where does this quote-unquote term managed care fit into that dialogue, into that debate? And that debate is driven in part by this recognition that while we've been, playing around with managed care for 50 years, while the promise of managed care has been that it would provide, lower costs and better outcomes, we still have performance which seems to lag behind our peer countries around the world. We still spend, as I said, way more than anybody else, but when we look at health system performance, it seems as if our performance is not very good. At the time of the debate in 2010, there were, really four different views, that were on the table as to how to get a handle on cost. Option number one, view number one, was we should do what many other countries do, what most other high-income countries do. We should, one way or another, regulate the price. Because if you want to know why the US spends so much more than any other country in the world, it's because the price of care is so much higher than the price of care everywhere else. Option number two on the table was, let's try to, some people said, well, the reason we have so high costs in the United States is because consumers have no incentive to save. Consumers basically just, somebody else is paying the bill, so let's give the consumer a high deductible health insurance policy, and let's have them have to really think before they go to the doctor. So that was option number two, the notion of high deductible insurance, et cetera, et cetera. Option number three was the traditional managed care route. The traditional notion of let's use incentives not on consumers, but let's give the provider an incentive to be more cost conscious. Let's give the provider an incentive to be more quality conscious. And then option number four was, it's not so much about incentives, it's just that there are these, there's 5% of the population that costs 50% of the bill. Let's focus on the high cost users. And we do that through care management, etc. Which of those four does the ACA predominantly focus on? Number three, incentivizing the providers to be more cost conscious. The notion of managed care and value-based purchasing. It doesn't really include, number four there, managing the high cost care. That's care management. That's not managed care. And that's part of the issue. We focus on quote-unquote managed care more than we focus on care management. And what managed care these days means in the United States is using tools both to incentivize lower cost care through value-based payment, but also using tools to try to incentivize higher quality care. But the tools we use to incentivize higher quality care, utilization review and prior authorization, et cetera, end up just being burdens that create more battles with the doctors. But here we are now in 2023. The concept of managed care, going back to Kaiser, is that original concept of care management, of blurring the lines between provider and payer, yes, but of really focusing on prevention and primary care and trying to, not be a sickness insurance company, but a health maintenance insurance company. But the managed care organizations that have evolved have been insurance companies that have said, we could use incentives, financial incentives, to move the dial both on quality and on costs. And the supporting evidence, at least so far, is pretty thin that there's a lot of value in value-based care. Doesn't mean, listen, the concept of value-based care, you cannot be opposed to it. I mean, it's kind of like, who could be opposed to the idea of actually paying based on value? But it is really hard to do. It's hard to come up with the metrics. How do you judge value? It's hard to come up with the data needed to judge, performance under those metrics. Meanwhile, as I said, the managed care organizations are increasingly the ones who are delivering care to our elderly and to our poor people in the United States. 75%. There are today in America, and I don't know how many of you realize this, there are about 93 to 95 million Americans, well over a quarter of the population, 93 to 95 million Americans who are on Medicaid today. The program that was created in 1965 to serve the poor now serves well over a quarter of the population. And most of those people will get their care delivered to them, organized for them, supervised for them by private for-profit managed care companies. Medicare, our program that serves about 65 million elderly people, increasingly is delivering its care, its services to the elderly and disabled population in the United States through so-called Medicare Advantage or for-profit managed care companies. One of the real key issues in American healthcare these days is what's the role of these managed care organizations in these public insurance companies, serving the poor, serving the elderly, serving the disabled. I mean, just to give you an example of how prevalent and how profitable the private insurance industry views public insurance these days, one of the largest insurance companies in the United States is Humana. Humana has decided they are exiting. They are no longer going to sell insurance to employers. They are focusing almost exclusively on Medicare, on public insurance, because that's where they say they can make the most money. And that should raise some questions. You should wonder about that. And part of that creates, I think, leads to sort of the third question I want to just put on the table for the conversation. The role of the so-called social determinants, the role of the quote-unquote non-medical determinants of health is achieving increased attention, appropriately so, in the United States and around the world. Everybody recognizes that you're not really going to get a handle not only on costs, but on disparities more generally. And you're not going to only have a better healthcare system, but a more equitable healthcare system unless you acknowledge the enormous role that an individual's race and their gender and their zip code, in their education and their health literacy, play in their healthcare. But whose job is it to address the social determinants? Whose job is it to address the social determinants? Is it the job of the individual physician? Is it the job of the managed care organization? Is it the job of now the ACO, the Accountable Care Organization? Is it the job of, the nonprofit organization? Is it the job of the community health worker? Is it the job of, the Medicaid, or Medicare leadership? Is it the hospital's job? Let me just sort of end, with just a minute or two on, showing my ignorance about Germany, which I probably shouldn't even begin to even raise, but just to say a couple of things. My sense is that here in Germany, there's been a fair amount of effort to try to use public reporting, particularly with hospitals, but very little effort to use value-based payment. So I think here in Germany, this question, and I think it's a question for an organization, that has managed care in its title. What does that mean in a country like Germany? What does being an organization, that's a managed care organization mean in a country in which there are relatively few managed care organizations, at least as managed care organizations are defined in the United States, but there's an effort these days to think about, the principles, the tools of managed care. Any conversation about policy needs to consider, I think, the 5 I's, whether that's in the United States, whether it's in Germany, whether it's about managed care, whatever it is. The first I is the idea. The idea. And maybe the idea is value-based payment. I mean, sounds like a good idea. Sounds like a really good idea. Then you have to navigate a political process. And I think this holds regardless of the country or regardless of the kind of system you're in. You have to think about who are the interest groups. Starts with an I, fortunately. Who are the interest groups that are affected? How's the power divided? What role do the pharmaceutical companies have, the hospitals, the doctors, the nurses, the dentists? Then there's, and here I cheat a little bit, I really should say culture, political culture, but the trouble is political culture starts with C. So it got ditched. But ideology, it's close enough. It's close enough. Where does our view about the role of government fit in? The United States, we're very divided on the role of government. Very divided on the role of government. And that's led to this not only huge partisan split in the country, but that's probably the core issue in healthcare these days. What's the appropriate role for government? What's the appropriate role for government? Institutional context. Where does the decision get made? Is it a Congress? Is it a regulatory body? Is it a single individual, in a more hierarchical, undemocratic country? What's the institutional context for decision making? And then if you finally get something through, then you have to implement it. You have implementation. And implementation is where the rubber hits the road. And I think, when it comes to managed care, I think the idea is a pretty good one. I don't think doctors should have total autonomy to do whatever they want to do. I do think there should be some kind of, blurring of the lines between the payer and the provider. I do think there are some organizations, whether it's Kaiser, whether it's the Mayo Clinic, whether it's Geisinger, whether it's Intermountain, there are sort of these handful of health systems that seem to have a better sense of how to sort of both balance the need for physician autonomy with also the need for sort of, more regulatory oversight. But it's implementation. It's how do you make the idea work? How do you make managed care work? That's where the rubber hits the road. And I think that's what the United States has been struggling with for 50 years. And I think we're going to continue struggling there because managed care organizations are not going away in the United States. They're not going away anytime soon because the label, is so appealing as a structure. But making that model work, implementing that model is an ongoing battle in the United States, and I think it's an ongoing question for countries like Germany as well. And I'd love to chat with Volker and all of you about some of these issues. So I'll stop there. Thank you very much.
I have to ask Lutz, the president of the German Managed Care Association, what are your takeaways when you are listening, Michael talking about, in a sense, also the different sides of managed care? You want to change the name?
So the concept that I see on the horizon, and I'd be curious to hear some more about it. You talked about it briefly, is population health management, is to include an entire population into a general system of managed care or care management. How would that be done?
When you think about population health management, and sort of distinguishing population health from population health management and managed care from managed care organizations, and who provide, to a certain extent, it gets back to the question I was raising earlier when I said, what's the role of an organization like New York Presbyterian Hospital? To what extent is their mission to care for the patients who come to New York Presbyterian and to provide them the best care they can provide? And to what extent do they have an obligation, either morally or should they have an obligation financially, to actually care for the community in which they exist, on the assumption that many of those people in that community are part of the reason that hospital exists, and they may end up as patients even if they're not. So I think where the United States went wrong, and where much of the world has gone wrong, is we've spent, ever since the end of World War II, we've spent an extraordinary amount of money on individual care. We've spent very comparatively extraordinary little money on public health and the care of the population more generally. And I think that's a tragic mistake. And I think, one of the ways, and I think public health is so weak, both politically and financially and otherwise, that I think one of the things the public health community has to do in order to achieve population health, the health of a community, is it has to better align itself with the classic medical care and healthcare system. And it has to create coalitions with that system. You know, if you have coalitions, we were talking about coalitions earlier, of academics who could sort of do sort of analyses of the health of a community, and then engage, and then have a sort of a management plan, you know, to engage the different sectors, you know, the classic medical care system, the education system, the criminal justice system, you know, the sanitation system. You know, I mean, we talk about health in all policies, but you really do need sort of what we used to call, we've replaced health in all policies with population health and population health management, but the idea is kind of the same, and I think, you know, making that work is one of the real challenges of the coming century.
Really quickly, so Michael, to your point, you know, every 3 years, the Affordable Care Act has a provision that every 3 years, every hospital system must publish its community needs assessments, which involves going into the community, building coalitions, building partnerships, identifying what all those community needs are, and then we publish those reports and also publish our strategy every 3 years. And the hope is that in 3 years' time, we see improvement in some of those issues. The problem is that we publish these reports every 3 years, but the metrics do not change. The implementation of public health strategies to impact the community has never really changed since we started publishing these reports that were mandated by the Affordable Care Act.
So thank you very much again.
Thank you.